the outset, thank you, Dr. Partha, Dr. Namrata, and the Ajanta team for having me here. It's a terrific academic meet. Pleasure to be in Kolkata. So I'll be talking about a very favorite topic of mine, ocular blood flow aspects in glaucoma, and I have no financial interest to share. So like all stories, once upon a time, progression occurred despite optimal IOP. When I was a resident, we were told about IOP. So we assumed the moment you lower the IOP, the glaucoma progression would stop. However, many trials said it did not. And the progression happened more than 45% over 6 years follow-up and 25% over long follow-up in EMGTS and AGS. So a question arose, what was the reason? Then prevalence was linked with the many studies, I won't go into details, but the LAIL study is one of the very important studies, and so is the Rotterdam study, which linked perfusion pressure as the risk factor for glaucoma progression. Once prevalence was linked, then it was but obvious that progression also would be linked. The Thessaloniki study and the Rojit study and the EMGTS talked about the MOP, which is the mean ocular perfusion pressure, and the circadian. Let's come to that. So much so that World Glaucoma Association in 2009's consensus said that compromised ocular blood flow, primarily low perfusion pressure they gave a figure of 50 to 55, and deranged vascular autoregulation was identified as independent risk factors for glaucoma progression and prevalence. So once the role was proved, it was but natural that indices would be found. And color Doppler emerged as the way to do it, and resistive index and the blood flow velocities, or the EDV and the SP, in the SPC and the short hysteresis with the artery was taken as the guideline. However, was it primary or secondary? We all know what came first, chicken or the egg. So that's a dilemma. So it was, is the glaucoma causing the vessel density loss, or is it the reverse? So we were unfortunate enough to be a part of the epidemic dropsy study in 1998 and 99. We saw multiple bleeds in these conditions. Patients died because of cardiac congestive failure. It was a leaking microangiopathy. Edema was there. And ocular blood flow was altered, and these are some of the pictures which we saw and published. And acute visual field effects occurred independent of IOP. So we realized firsthand that ocular blood flow is implicated. However, over an 18-year follow-up of 5 of these patients, we found that their visual fields did not deteriorate because these patients had healthy autoregulation. In 2007, we decided to do a study post-trabeclectomy where the IOP is controlled. We did a color Doppler in 40 paired eyes. Now, paired eyes is something we took because the other eye serves as a control, natural control. So one eye was subjected to trabeclectomy, and we had the neurology team, neuroradiology team with us who did the color Doppler imaging. SPCA was the most difficult to pick up because never the same one in sequential follow-up, but yes, we could identify in the central retinal artery, ophthalmic artery, and the SPCA, a few of them. And we did find that there was a trend towards increasing blood flow post-trabeclectomy. So control of IOP led to improvement in blood flow and not only IOP. In 2014, we had this interesting patient, a 48-year-old lady. She had very asymmetrical glaucoma, and she also had coexistent ophthalmic artery stenosis. As just told, most of the neurologists will say do nothing and they put them on aspirin. The IOP was 30 in the affected eye, and in color Doppler imaging, we could actually demonstrate the loss of the ophthalmic flow. This diastolic flow was totally lost. She required trabeclectomy, and 6 weeks post-trabeclectomy, we showed improvement in the end diastolic velocity from 0 to 6.7, which was a very significant. So literally, yes, the egg came first, the blood flow problem came first, and then was the glaucoma. Very recently, we did again in the paired eyes, asymmetrical POAG, and we could literally prove that nasal and temporal, because now the imagings had evolved, and we correlated these pressures and the ocular blood flow with night time. And this is when we realized that ye kahani ek raat ki hai. Remember, all the ischemic optic neuropathies always happen early morning, early morning or late night, because that's when the blood flow changes. So what happens at night? Normally, physiologically, there's a dip in the blood pressure in two-thirds of healthy individuals. Some of us are non-dippers where the dip is absent or blunted, and they are at more risk for CVS events. Some of us are over-dippers, which are called as more than 20% fall, and these patients are the ones who progress more, with the central visual field being more susceptible. So therefore, to pick up these dippers, non-dippers or over-dippers, we did a 24-hour ambulatory blood pressure and IOP. In addition, it's not only the sleep, it's night time, it's also the posture. How you sleep, because that also is a head elevation or head straight. So there's a perfusion pressure loss in the evening, and as told, the OSAS or the sleep apnea is emerging as a big risk factor. So कहानी रात की है, कैसे सोते हैं, as कितना आपको apnea है, and what is the dipping of your blood pressure. And we could show in this study that advanced damage eye, we took two, the paired eyes, as we said, the advanced damage with the less advanced damage. And in the advanced damage, we could show a correlation with the IOP reduction and with the less advanced both. But the blood pressure perfusion was less in the more advanced. It has been proven by other studies that Octa has come up now, and moderate and severe damage is talked. So a recent last study was again paired eyes with advanced damage with intervision is disparity. For 100 eyes we took, both eyes had 0.9 cupping, but one eye had poor vision, one eye did not have poor vision. And we did the macular vessel density, optic nerve head vessel density, and we found that the macular VD correlated maximum with the visual acuity. However, as talked about by Dr. Manish, the signal strength was poor in many of these patients because of poor fixation, and we could not check those patients. So MVD emerged as the best predictor for poor vision. And this has now been documented that macular VD is correlated with RC dysfunction even before the functional change is apparent. Second part of my talk would be, we all are ophthalmologists, we tend to focus on IOP, on the OCT, on the visual field, on the gonioscopy. We forget that the eye is part of a human body. And the human body has hypertension, diabetes, OSAS, migraine, hypercoagulable states, thyroid, and all these conditions have an impact on glaucoma. And as I was talking about the late study which was done in patients with open angle glaucoma and no glaucoma, and they found that low perfusion pressure, especially the hypertensives, was significantly associated with prevalence of open angle glaucoma. And the strongest relation was in those with poorly controlled hypertension and untreated hypertension. Same thing, Thessaloniki, I started talking about the diastolic OBP and effect of, in this study, the antihypertensive treated patients were not affected. Diabetes, we all know, incidence of glaucoma is increased not only by diabetes but also by the microvasculature. And the retinal vessel diameter is independent of the diabetic retinopathy. So this glaucoma is independent whether the patient has DR or PDR. However, the study by Vijay et al. Said that this is not so, but most studies otherwise talk about that diabetes is linked. The third is the vascular dislocation. We know about the secondary VD or vascular dislocation by rheumatoid arthritis and rheumatoid arthritis, but PVD is something we need to know about. It's primary vascular dysregulation or the Flammer syndrome, seen in slender women, starts at puberty, improves at menopause, is linked to hormones. Cold hands, cold feet, migraines, nocturnal dips of blood pressure is there. So we need to start looking for these, and nail fold capilloscopy and all the ocular perfusion will be tested for this. So I have talked about two aspects. Yes, it is linked. Yes, it is linked to prevalence and progression. And yes, there are multiple diseases and comorbidities. So what are the clinical implications of all this? What do we do about it? When all to suspect ocular blood flow? Always. Or tailor it. We have to tailor it when the neuroretinal rim pallor is disproportionate to the disc or the visual field damage, especially in asymmetrical glaucomas. When there is progressive and disc damage or visual field damage despite good IOP control. After that, remember that this should not be white-collar patient. White-collar hypertension or white-collar means that they would be putting the medication when they come for a visit. So look for adherence over the month. Just ask them कितनी बारी दवाई आपसे miss हुई थी, so that you give them a way out. If they have good adherence and despite that they are progressing, then look for other causes. And in these situations, look more aggressively, do the MRIs, do the neurological workup. However, most people say that the red flags are younger patients, poor vision, pupil changes, color vision, visual field defect, not proportional disc damage, and pattern. Once we suspect, what do? Do a phasing, do a diurnal variation of BP measurement, look out for ocular vision pressure, especially at night time. And once you have that, you can go for carbonic anhydrase inhibitors, low kinase inhibitors, or latanoprost. Do not, patient, if it's hypertensive, do not overtreat, do not lower the diastolic BP lower than necessary. And if nocturnal dip is there, then shift the BP medications. PVD, usually you don't treat unless there is disease. Lifestyle management, avoid triggers of vasospastic episodes. Nutrition, avoid excessive cleanness, no fasting, salt and fluid intake to avoid excessive dips, and sometimes magnesium is helpful. At the end, I would like to salute Dr. Sohan Singh Maire, who talked about ocular perfusion pressure and optic nerve head insufficiency in 1970, almost 50 years down the line. Salute to this gentleman who put up this point. Thank you very much.
I think this is a very difficult topic. A lot of people have confusion on this. Thank you for making it so lucid. And request Tuli sir one comment. In your practice, which are the patients where you look into the ocular blood flow and what are the clinical signs you look for?
I think one thing is that this is very difficult to measure. So in everyday practice, so if ever you are in doubt that OBF could be a culprit, then empirically you can treat with optical CAIs. That is the only thing we can do empirically. I think with unexplained progression, or when apparently the pressures are on target, and still you ruled out ankylosis and everything, still the patient is progressing. This would be a situation to suspect something in the OBF. Obviously, if there's a obvious pathology in the carotid or something, that is different. But in unsuspected carotid disease or heart disease or other things, I think empirically we can give topical CAI. This is very difficult to measure. I think I was just talking to Sumita, it's very difficult in Kolkata also to measure. They've tried to do with radiologists, but I think it's difficult to measure. Ma'am is different. Ma'am to sab kuch kar leti. So ma'am to concern.
Actually, whenever you have it, the radiologists are more than happy to do a color Doppler. And now their imaging devices are so refined that we used to think that short posterior arteries can't be picked up. You will be amazed to see that they can be picked up. But once you have diagnosed them, karo kya? No, ultimately, even if there is a stenosis there, what will you do? So the treatment is more difficult. So the systemic comorbidities have to be focused at and they have to be treated, as I pointed out.
And we often do that. We often empirically start on dorzolamide if we are suspecting this, or there is no other cause to explain the progression.
Just one more comment from Dr. Lala. Yeah, madam.
It is difficult to measure ocular blood flow or ocular perfusion pressure, but clinically, how do we see? How do we get what is the importance of it? Is diastolic blood pressure minus IOP. It has to be more than 55. If it is less than 50, 55, then it becomes clinically significant. And I think what Dr. Tulip discussed that unexplained progression, but what I feel in unexplained progression, especially at low IOP, then there are a number of other factors which we need to see, like what is the DVT, is there any history of steroid use or just nocturnal hypotension. There are a number of other factors which before coming to this point of this perfusion pressure.
Thank you. Dr. Lalwani, I think one point where Dr. Tuli made that we should use carbonic anhydrase inhibitors. Will you stop using beta blockers in these patients also if you think there is a vascular issue?
Yeah, definitely. If a pressure patient is on hypertensive and cardiovascular patient also, and he is taking antihypertensive with a beta blocker side, so we should stop beta blocker topical timolol. And I say the systemic comorbidity should be addressed properly. Many patients not tells you what he is taking for, what he is not taking tablet. So systemic comorbidity is the main issue. After, and many times this forum also says homeopathic and Ayurvedic medicines they were taking for the control of their diabetes and hypertension. So this should be ruled out before that you have to go for ocular blood flow study.
Thank you. So I think healthy eye is a part of healthy body.